Ladies and gentlemen, welcome to the Cardiac Family channel. And today we are going to discuss about an investigation called as CT Coronary Angiography and what are its advantages, benefits, its risk and everything about it. Hey, this is Dr. Avinash Namdar. I am a cardiac surgeon. On my right you have Dr. Sanjeevani, who is a cardiac anesthesiologist, intensivist and echocardiographer or echocardiologist, and to her right you have Dr. Sonali, who is an interventional cardiologist. So let's begin with the discussion on coronary CT angiography. So first, people would like to know what exactly is CT coronary angiography.
So coronary CT angiography is a radiological test which is done in the radiology department, in which a angiogram of the arteries, that is the arteries that supply the muscle of the heart, are studied. You inject a intravenous contrast agent while doing the test, and the patient lies down in that CT scanner, and by using X-ray we get a picture of the coronary arteries, and we understand whether the patient has any, number one, whether the patient has any evidence of coronary artery disease, if there are any blockages or not, and are these blockages significant or not. That is, are they obstructive blockages, that is more than 50%, or are they less than 50%?
Okay. So are these investigations, are they performed by a cardiologist or a radiologist?
Well, it depends on in which part of the world you are in. Generally in the Western world, there are specialist imaging cardiologists who train themselves in CT, MRI, echo. So they generally do it. But in our country, more often than not, it's the radiologists who conduct this test.
There is another question is people ask us, what is the type of machine we should go in for? There are, I believe, different slices, what they call a 64 slice CT angiogram machine, or 128 slice CT scan machine, or a 256 or a 512. So which is the one that you recommend?
Well, greater number of slices the better, because the accuracy is very good, because CT angiography is an anatomical test. We see the structure of the coronary arteries. But generally in most hospitals in our country it is 128 slice. The thing is, even if it is 128, we need an operator, that is a radiologist, who is able to interpret and understand the blockages, understand the stenosis, the obstruction, and correlate it with the patient's symptoms. So that is most important. We have had radiologists who've had a CT angiogram done, who've interpreted a CT angiogram of a patient, and if that patient has been subjected to a gold standard test like coronary angiography, then they've come to the cath lab and seen whether their interpretation was correct or not.
It matches or not. I believe in our country we have a couple of machines of 512 which is supposed to be matching very much.
It matches well, but then again this is operator dependent also. So this is just like machine learning. We have something known as human learning.
This is how they learn.
This is how
and they
learn,
become
and this
expert
is how
and expert.
all of us contribute towards making a correct diagnosis.
Now the important question is, in what patients would you do a CT coronary angiogram, or in what patients would you subject them to the conventional gold standard catheter angiography?
Well, so it all begins with computing the pre-test probability of a patient. So in short, you have a patient with some symptoms like chest pain or breathlessness. Then you know the patient's age, you know the patient's gender. Based on these parameters, you find out that there are these tables which are already there to understand the pre-test probability. It is in the part of percentage. So if the pre-test probability is between 15 to 50, that is 15 to 50%, it is intermediate test probability. So they are neither at a very high risk nor are they at a very low risk. If it's a very low risk patient, you just leave the patient. You don't further do any testing unless there are some red flags. If it's a very high risk patient and the ECG is very abnormal, the 2D echo is grossly abnormal, they directly go for a coronary angiogram. Or if they are presenting with some kind of heart attack, they go for a coronary angiography, conventional one. Intermediate risk patients are the ones who need further tests. Now there are two types of tests. You have anatomical tests like a CT coronary angiography, that tells you about the structure of the arteries and what is if there are blockages or not, and if there are blockages, what is the percentage of blockages. The other type of tests are functional or physiological.
Physiological,
They
yeah.
are stress test based tests. So for example, we have the typical stress test, which has actually become quite old because it doesn't, its sensitivity and specificity
It's quite low. It's
that is
about
very low.
85%.
Now you have more sophisticated tests, like we talked about the stress echocardiogram,
Stress echo, yeah.
stress MRI is also there. Then there are stress nuclear tests like SPECT or PET, which are nuclear medicine based tests, which are not available everywhere. But in general, all of them are grouped together. So these are physiology and anatomy.
Right.
So now it depends. In an intermediate risk patient who has a pre-test probability of which is intermediate, you have to decide based on each patient. If you feel based on their symptoms, based on their risk factors, that the probability of them having a obstructive coronary artery disease, and what do you mean by obstructive? That is something more than 50%.
50%,
Yes.
yes.
If you think that is not there, you know, the probability of them having an obstructive disease is less, then you, to rule out a obstructive disease, you can go for a CT coronary angiogram, especially in people who are younger, who are less than 65 years of age. You can rule out an obstructive disease, but at the same time you come to know if there is non-obstructive blockages, and that is also useful. That information helps you to start preventive medicines, so that in the future they don't get obstruction.
Correct.
On the other hand, physiological tests that are stress test based tests, they do not detect non-obstructive diseases. They only detect something which is significant, more than 50% or more than 70%. So patients who are older.
As a screening test, would you recommend CT angiogram to all those
No,
patients?
not to all.
Not to
Not
all.
to
Now
all.
we have a lot of these IT patients walking into a clinic
Right.
with a very high screen time.
Right.
They have a sedentary lifestyle.
Right.
Their cholesterol is high. There is a lot of dyslipidemia. And then, would you just, as a blanket test?
No, not
would you
as a
just tell
blanket.
them?
You have to evaluate each patient
Why?
individually.
Are there any risk factors? in this
Radiation.
case?
You don't want to subject them to a test like CT as often as you subject them to an echo, for example.
I think the
So how much radiation is there?
Yeah, so for example, if you take a chest X-ray, a single chest X-ray, the amount of radiation is 0.1 millisieverts.
Yeah.
That is the way we compute the amount of radiation someone
Units.
receives. Yeah, the units. When it comes to a CT coronary angiogram, it is 8 millisieverts.
So it's like
80
taking
times. 80 times.
It's like taking 80 X-rays.
Yeah.
80
So
X-rays.
one
Yeah.
CT angio is 80 X-rays,
80
which
X-rays.
is quite a
Of course,
high.
but if it is more sophisticated, if the
Then
number
it
of
is
slices
less.
are more, the amount of radiation
The
will be
radiation
less.
is
So this is just a
inversely
blanket
proportional.
statement.
Yeah.
And of course, when you do a CT angiogram, you also do something known as coronary artery calcium score.
Calcium score, yes.
So that tells you how
Which
much
we have
calcium.
already
We've
discussed
already
in one of
discussed in
the
another video.
videos, yeah.
So it tells us how much calcium is present in coronary artery. Now, that just is a risk prediction.
Risk prediction. It's one of the
prediction,
markers, yeah.
risk prediction tool rather. Yeah. So if the coronary artery score is more, you know
More
that
means how much?
so
More
if-
than 400?
More than 400.
Would you still go ahead and do a CT angiogram?
Yes,
or-
if it's more than 400, a CT angiogram would give us information
Yeah.
about the obstruction. But if it is very high, in its
Like what?
thousands,
It's more than 1,000,
Yeah.
you would not do
you
a
will
CT.
not do it. Depends. Like if that calcium is very dense,
Yeah.
you will not be able to understand the coronary
Yeah,
anatomy.
there
It
will be
obscures the
there will be
anatomy.
so much of opacification there, you would not
It's a
see
waste
the
of a test.
coronary.
In fact, the radiologists call up and say, no, the calcium score is too much. We
You
cannot
can't do it.
interpret the angiogram. So why don't you do a conventional coronary angiography to understand? Because we have to know that just because there's more calcium, it does not mean that the patient may have obstruction
Yes,
inside the
yes.
coronary.
Yes,
Because
that we have
calcium,
discussed.
that calcium can be on the outer layers
layer
of the
also.
artery also.
Now, I believe when people go for this CT coronary angiogram,
Right.
not all patients are eligible. Some of them are rejected for some
yeah.
reasons of heart rate and like that. Can
Yes,
you
yes.
throw some light on
Yeah,
that?
so you need a certain amount, a certain heart rate when you are subjected.
be less
to
than
it. It should
60,
be less
yeah.
than at least 80. And it should be ideally less than 60 actually.
Yeah.
Yeah, you're right. Some patients have irregular heart rates.
Yes.
Then you may not be able to do the
Like
CT
atrial
coronary
fibrillation
angio. Yes.
or multiple ectopics.
Yeah, so you might have to change the medications a bit before to bring the heart rate down and then do it.
So, in short, CT coronary angio has certain specific indications, not like a blanket investigation to be done in suspected any sort of coronary
Correct.
angio,
Yeah.
coronary artery disease.
Right.
isn't it? I would
Right.
say that.
In
yeah.
few of our patients, because they couldn't give beta blocker, that is heart lowering agent,
Heart, yes,
because the patient had low ejection fraction.
Or
so
the
in
patient
such,
could have, had a side effect of
or
it. Then there is
then
no
of
other
course
option but
it
to
cannot
do
be
a
done. So there
coronary
are limited
angiogram.
indications.
Right.
Right.
So suppose company gives you this package every year free.
Yeah, no,
So
don't do
one
it.
should do it or not.
No, if you do a CT coronary angiogram once, don't do it at least for the next 5 years unless it's clinically indicated.
5 years. Oh.
Yes, you don't do it because
otherwise you will
are
land in-
subjected. Yeah, I mean you don't have to do repeated.
But in comparison,
CTs.
wouldn't you say that the conventional coronary angiogram has a less
It's
amount
got
of radiation?
less half of the radiation of that, or in fact more than half of
Less than
of the
half, yeah.
radiation.
So every year one can do echocardiography, stress
Yes,
echo,
that-
stress
those are
echo is-
physiological.
it's
but
quite-
not
it's quite-
these days. That is very important message
Right, because
we would like to give
radiation
you.
has its harm in the future. Risk of cancers can increase, risk of fibrosis, risk of heart
And that will
blockages.
come after 10 years, 20 years.
As a screening test after
Right.
say bypass surgery that we have done or your angioplasty
Yeah.
to look for the patency of the stent or maybe patency
Mainly
of the graft, it is a very good investigation, I
Yeah.
must say.
For the
that,
graft
we
patency,
don't have
it's
to
a-
go
it's
in
a
and
good-
do that test.
Yeah.
Now if the patient is totally asymptomatic and he is very keen that to rule out coronary artery, that's a very good investigation.
Yes, and
isn't it?
in fact, coronary artery calcium score is even better because it's got a little lesser radiation. It's just 1.7
And
millisieverts.
apart from blockages, if there is an abnormal coronary artery
Right.
which
Yes,
is taking
yeah.
off
Anatomy.
from, coming from the back of the pulmonary artery, and,
Or whether if it's going between the two
the
arteries,
pulmonary artery and
which can
aorta,
get compressed.
or
Like some of
maybe
these
there
rarer
is going
causes.
having a left LAD having a muscle bridge, going
yeah.
inside the muscle and
Sometimes,
coming out.
yeah.
Those
Sometimes-
things also
Sometimes
can
you
be
can even get
identified, yeah.
muscle bridges. Of course, that is seen very properly
Such
on a
anomalies
coronary
can give a
angiogram.
positive stress test,
Yeah,
and
yeah.
then one would think that he's got a coronary blockage, but this is all a coronary anomaly.
Yeah, these are the rarer causes
Of course,
of
rarer,
positive,
but we do
right.
find them quite often
In fact,
nowadays,
even when you subject a patient to any kind of CT, you have the other artery, that is the pulmonary artery.
Yeah.
If there are clots in the pulmonary artery,
That
incidentally
also.
you can just look at that and or the pulmonary artery looks very big.
Yes.
Then the cause of chest pain may not be the coronary artery
Yes,
at all.
yes.
It may in fact just be
Because
a pulmonary embolism. So
yes,
I mean other causes can
And in
also be ruled
COVID
out.
situation, in COVID period, we saw many pulmonary embolism,
yes.
thrombosis.
We've seen both
and
also
we
in
have
one
treated
patient.
it very urgently, and patients are surviving.
They-
so
yeah,
it is that important.
Yeah.
So, ladies and gentlemen, in short, this CT coronary angiography is a very sophisticated investigation, and you should get it done only under expert guidance. Just don't do it as an OPD basis. Unless it is really advised by a cardiologist, do not go for it. It has its own limitation and it has its own risk factors involved in it. So, ladies and gentlemen, if you like this video, please share and subscribe to our channel, and I look forward to meet you again in the next video. Thank you very much.